Thank you very much. It's a real pleasure to be here in this beautiful city and spending some time with you going over some of the interesting concepts in heart failure, which is the disease that we all try to fight and combat. And I'm going to talk to you briefly about a topic that's of great interest and not so much as a major comorbidity, but as a therapeutic strategy, which has to do with the interaction between the brain and the heart and how can we fight or combat that interaction for the purposes of achieving therapeutic interventions. And it's been very clear to all of us that there is a significant reduction of mortality by pharmacological neuromodulation. In this slide, you can see the reduction in mortality that's observed with an angiotensin receptor blocker, with ACE inhibition, with beta blockade, and mineralocorticoid. But in essence, this slide points to us the important reduction in mortality that's been achieved by significant pharmacological neuromodulation, which further can be demonstrated by this very late recent trial on a new drug, neprilysin, which demonstrates that we can further improve in mortality by augmenting the neuromodulatory responses in the heart failure milieu. But heart failure is a complicated condition because in a study that we conducted years ago, and it's been reported in the literature, the average number of medications that our patients take, it's at least 7. And when you look at that, and when you look at the importance, the relevance of those medicines with the potential interaction with blood pressure and heart rate, it becomes rather difficult for a single individual to be taking all these medicines. Therefore, an attempt to decrease neuromodulation or to modulate the responses that occur in a non-pharmacological way, it seems extraordinarily attractive. And in some way, we've done that through pacing, we've done that through devices, and the opportunity arises in understanding how these neuromodulatory responses occur and lead to improved outcomes. And there are a variety of strategies that can be used to do that. What are the principles of non-pharmacological neuromodulation? Well, it's clear that heart failure is associated with an autonomic imbalance where there is a predominant sympathetic activation over the parasympathetic response. We also know that suppression of markers of the vagal tone is predictive of worse outcomes. For instance, heart rate variability, heart rate turbulence, and the varoreflex sensitivity. We also know that pharmacological increases in vagal tone with beta blockade lead to increased survival. So there are at least 3 major strategies that can provide neuromodulation in a non-pharmacological way. And those are listed in this slide. One is the vagal stimulation, direct vagal stimulation. It provides an efferent parasympathetic response. There is carotid sinus nerve stimulation that provides a reflex parasympathetic response. And there is a spinal cord stimulation, and I'm going to dwell into that a little more since we've conducted an important number of observations and trials. So I'm going to approach each one of those briefly to give you an overview of how we can achieve non-pharmacological neuromodulation. Vagal stimulation is probably one of those that have the most advanced clinical development. Vagal stimulation consists in the application of a device that directly stimulates the vagal tone. And in experimental animals, this slide is provided by Hani Sava, shows that there is an improvement in end diastolic area following vagal stimulation in animals that have heart failure compared to control, as shown in this slide. This is the change in end diastolic area in animals treated with the vagal stimulator. When we look at NT-proBNP, we can see that in the heart failure animals, there is a significant increase in the NT-proBNP and a reduction following vagal stimulation. The same thing you can observe in the 3 important measurements that were obtained by Hani in this particular study: calcium handling, apoptotic signaling, and inflammation. In all of those, the application of vagal stimulation led to improved calcium handling, decreased apoptotic signaling, and decreased inflammatory response in heart failure dogs. So from an experimental standpoint, it does appear that vagal stimulation provides what we want to achieve with non-pharmacological intervention. That and a few other smaller observations led to a landmark study that was recently published in the European Heart Journal, presented the European Society of Cardiology last year, that's called the Nectar Heart Failure Trial, presented by Dr. Senad from France. And I'll highlight some of these findings to you. Vagal stimulation is shown in this slide. It's very similar to a pacemaker device. It's an electrical power source that goes with the lead and activate the vagal nerve. The protocol for implantation and stimulation is shown in this slide, and I'm not really going to go into that. But I highlight to you the importance of conducting these type of trials, whereas you can see about half of the cases were implanted by neurosurgeons, and 2/3 of the cases were implanted by cardiac or vascular surgeons. And the complexity of the trial really resides into the multiple specialties that really have to put together to organize a study like this. The primary endpoint of the study was the left ventricular end systolic dimension, as shown in here, and there was really no significant difference. The full publication, as I said, is in the European Heart Journal this year. 6-month safety results are shown in here, and there are no significant differences between those in the active therapy and in the control group. Maybe some trends, but no significant differences. If you look at those in active therapy, there's only 1 and 2 in the control group. Statistically, it really provides no significance in any of the parameters studied. So vagal stimulation may continue to be studied under specific different sets of implantation and programming the device in a slightly different form, with the expectation that you can achieve a more powerful, more robust response. But at this moment, clearly, it's a negative study, despite the fact that experimentally it provides enough basic information that suggests that there may be a beneficial effect. Carotid sinus nerve stimulation, it's another technique, another set of procedures that can be implemented with the purposes of providing neuromodulation. And this animal work from Zucker, published in Hypertension in 2007, shows an improvement in survival in animals, in dogs, induced to develop heart failure that have various stimulation applied. As you can see in this Kaplan-Meier survival curve, animals treated show a prolonged survival. You can also look at neurohormones as another marker of the biological efficacy of the therapy. And when compared to controls, animals treated with various stimulation had decreased plasma norepinephrine and decreased angiotensin II levels, indicating the consistency of the observation in the survival as well as in the neuromodulatory responses. Various stimulation is also a strategy that decreases inflammatory markers, and this slide shows the change in neopterin. And as you can see in heart failure animals, there is an increased expression of neopterin that is significantly reduced following the application of various stimulation. This is the device that's being used in clinical trials, and one of the most important studies was conducted by Eduardo Gronda from Milan. And this is the device, the size of the device, and a small surgical puncture and a small surgical incision is required at the carotid area. The device electrically activates the varoreflex by stimulating carotid varoreceptors. It's a unilateral implant. It's a very small electrode, a small neck incision, and is programmable via radiofrequency telemetry. And the therapy is usually individualized, looking at the heart rate and blood pressure response. The results that I'll show you represent the data from a single center study from Milan that's highlighted the protocol in this slide. And the data on that study is shown in here. The data shows the number of hospitalization in patients that were followed the preceding 12 months, as shown in blue, versus those following activation of the therapy. And it shows a remarkable difference compared to the historical number of hospitalizations, suggesting that the application of various stimulation may provide significant clinical responses. So those two areas of investigation opened the field for another strategy that's called spinal cord stimulation. And the spinal cord stimulation is shown in this slide. This is a technique This is a technique where in the spinal canal, a lead is implanted, and the lead is implanted at the level of the cervical, thoracic, or lumbar area that you want to interfere with the transmission of signaling. It typically is used for patients that have pain syndromes, and in the US, the most wide use of these technologies for patients that have failed back syndromes, and they're typically located in the lower thoracic or in the lumbar spine where this pain syndrome occurs, and electrical activation of the spinal cord suppresses the pain sensation. It also provides or causes vasodilatory responses. The rationale for the use of spinal cord stimulation in heart failure is shown in this slide. Spinal cord stimulation has limited impact on myocardial blood flow, though there have been some studies using MRI and using nuclear imaging that shows a mild but significant and reproducible improvement in myocardial blood flow. When measurements have been obtained in coronary sinuses, spinal cord stimulation decreases catecholamine levels. Depending on the location of the lead, it also provides peripheral vasodilatory responses. And in a single animal study published by Lobshire and Doug Sipes a few years ago, it shows that it does decrease ventricular tachycardia, ventricular fibrillation, and it leads to an improved or preservation of ventricular function. And I suggest to you that if you're interested in this topic, there's a great recent review in Europace 2004 that highlights the spinal cord stimulation and the other two techniques that I previously discussed with you. This slide is out of the Lobshire and Doug Sipes paper in Circulation 2009, and it shows a very important but significant finding. These were canines, dogs that developed heart failure using multiple microemboli in the coronary, in the LAD. And this is the EF at the beginning of the trial, at the beginning of the study. Following infarct, the animals show a significant reduction in ejection fraction. And in these animals, the spinal cord stimulation was applied at the beginning of the infarct. And at the end of the study, there was a significant recovery of function as shown in these yellow bars in animals that were treated with spinal cord stimulation. So the observation suggests that the application of spinal cord stimulation at the time of myocardial infarction led to preservation of ventricular function and an improvement in ventricular volumes, in systolic and diastolic volumes at the end of the study. Applying this technique to humans is challenging. The spinal cord stimulation is not in the hands of cardiologists. It's not in the hands of interventional cardiologists. Typically, neurosurgeons and pain management or anesthesia interventional anesthesiologists are the ones who have trained to implant these devices. So at Methodist Hospital, we had to conduct an effort to develop a team approach to this particular intervention, just like it is now the standard for complex interventions in the cardiovascular field. So we have anesthesia, pain, EP, because of the programming, because of the potential impact in atrial fibrillation, ventricular tachycardia, and ventricular fibrillation, heart failure, and neurosurgery. And after multiple discussions, it was also important to decide where or how do you implant this device? Is it done in the operating room? Is it done in the cath lab? And we decided to do this in the cardiac catheterization laboratory, just like one would do a pacemaker in the cath lab. And this is a slide of one of the first patients that we implanted at Methodist Hospital. So we elected to conduct this procedure in multiple approaches. We developed two different protocols. The first protocol is shown in this slide. And as you can see, we apply a lead to the upper thoracic spine from T1 to T4. The nerves that arise and arise from the thoracic spine to the area go to the heart, and blocking those nerves may lead to improved peripheral vasodilatory responses, decreased catecholamine production, and reflex parasympathetic tone. T1 to T4 is equivalent to what was applying the dog model that led to a significant reduction in ventricular tachycardia and preservation of ejection fraction. The outline of the protocol of our first study is shown in this slide, and it's published in the European Heart Failure Journal last year. And we randomized in a crossover manner about 10-15 patients that went into an active phase, randomized against an inactive phase, with a crossover where the inactive phase would be crossing over to an active phase and the active phase down to an inactive phase. So all patients were implanted. The mode of activation was blinded to the investigator, was blinded to the patient. Although the patient sometimes can feel some paresthesias, we made an effort to try to avoid recognizing those signals, at least by the evaluators. This is an X-ray of one of the patients that has the lead implant in the T1 to T4 area. As you can tell, all our patients had CRT and ICD devices because this protocol was conducted in patients with significantly depressive ejection fraction. So therefore, one of the most important observations of the study was the interaction between the device, the electricity emitted by the defibrillator, and the electricity emitted by the spinal cord stimulator, whether this could provide signals that prevent the defibrillator from properly working, as well as the spinal cord stimulation for properly working. The demographics in this very initial set of patients is shown in here, but suffices to tell you that all of them had devices, significantly reduced ejection fraction, and these patients were class 3, class 2, and 3. This patient with class 2 has significant limitation in exercise capacity. The most important observation of these initial observation was the safety parameters that I will discuss with you. We had no significance. There's a very small study. We really had only one patient that died, was a patient that was randomized to the not active form of the study, the same number of hospitalizations for heart failure. And of interest, the patient that died, at the moment that died, of course, we didn't know whether he was randomized to active and inactive form. And we unblinded that patient, and to our surprise and of course to the great anticipation of the study, the patient was not actively treated. That would have created a big problem for the study. When you're doing a small trial and small observations, one single negative event may completely dissuade you from conducting the study. The FDA monitored this trial very closely, and after revision of that particular event, they allow us to continue to conduct the study. And following these observations, we were able to obtain Medicaid approval to conduct this in the state of Texas. This slide shows also another safety signal that demonstrates that when we have the device, the spinal cord stimulator on, there was no significant noise in the device, and we were able to detect ventricular tachycardia and ventricular fibrillation without any significant delay following the active induction during VT induction in the cardiac catheterization laboratory. We measure a variety of efficacy endpoints as shown in this slide, but these are simple observations that don't provide any substantial measure of efficacy. It only demonstrates the fact that we can measure, and in the larger cohort of patients, we're trying to do that. We have a new study being conducted at this moment. It's a study where we implant 2 leads, one in the upper thoracic spine, one in the lower thoracic spine. The upper thoracic spine is attempted to do direct cardiac modulation, the lower thoracic spine to provide vasodilatory responses. So let me summarize for you these last 10-15 minutes of conversation in this field. And I'd like to suggest to you that spinal cord stimulation can be performed safely in advanced heart failure patients, that there are no significant adverse device-device interactions that may hamper the probability of studying this in larger patient population, and that signals of benefit indicate that further studies should be conducted, not only spinal cord stimulation, but in the various stimulation in the vagal stimulation trials. And I think exploring cardiac and peripheral targets for therapies like this that are non-pharmacological may be of great importance in the future. Thank you for your attention.